Hi, everybody. I'm so glad that you made the effort to come out. I want to spread some information, especially about the safety of cannabis therapy. We can talk specifically about cannabis use in patients with cancer, of course, but that will only be about 20% of what I talk about. The other 80% will be general information, what cannabis is all about, how to use it, how to obtain it, and why I believe it's safe. And I'm hoping that when we're done, you'll come away with a good feeling about cannabis as an option for you. In general, we will start with the history of cannabis therapy. You know, cannabis has been around a long time, and we'll go into that a little bit. It was used for different things over the years, spiritual aid and relaxant, but also as a remedy for a number of conditions. We'll talk about the words that we need to understand in order to have an intelligent conversation. CBD, of course, pretty much everybody knows, at least has heard about CBD, but what exactly is it? And how is it different than THC? Different types of cannabis plants, different ways of using cannabis will be covered. We'll talk about my favorite topic, the human endocannabinoid system. You've heard of the skeletal system, the digestive and pulmonary systems. Today we're going to talk about the endocannabinoid system. We'll also, of course, talk about specifically how cannabis can help patients who have been diagnosed with cancer. And then, of course, it's important to talk about the risks. Why not to use cannabis, or what care specifically do we need to take when using cannabis therapy. And finally, we'll talk about specific regulations and requirements for Florida residents, and that includes permanent and seasonal residents who can use cannabis legally for medical purposes here in the Sunshine State. So I don't intend for you to read this small print, but I like the way this 6,000-year history of cannabis graphic shows how in Central Asia, beginning 5,000 years ago, that's 3,000 years before the Common Era, we have documentation that cannabis was used for medicinal and spiritual purposes. And then over the next 1,000 or 2,000 years, cannabis as a remedy for different conditions was documented throughout Asia. We have the earliest pharmacopoeia, which is the manual of medications and their uses. Here, that was recorded in Asia, including how cannabis was effective for a variety of conditions. And then cannabis, you know, is a plant. People have a relationship with plants for different reasons. Sometimes it's medicinal, sometimes it's industrial. Early on, it was used also as one of the most important industrial crops, and we're still dealing with that today, thank goodness, as hemp. And we'll discuss the difference between hemp and marijuana in a few minutes. But the benefits and the usefulness of cannabis as an industrial crop was recognized thousands of years ago. Then, as a medication and a spiritual aid, it was used in India as part of what we call Ayurvedic medicines. And eventually, the Greeks and Romans took it up. And again, we have documentation about cannabis as being used for different conditions. This Arabic text talks about its use in epilepsy. Then William O'Shaughnessy, an Irish physician, now we're getting into the Common Era here, he was visiting India. He discovered that cannabis was very effective for a variety of conditions, including people suffering with rabies, who, of course, at that time, now we're talking the 1880s, the end of the 19th century, people with rabies would get these terrible tetanic spasms, and they couldn't breathe, and then they would die. And it turns out that those individuals given cannabis therapy in India had a relaxation of those muscle spasms. Unfortunately, they still died from their illness, but they were able to relax, and it was a very potent analgesic. He took that information back to the UK and Ireland and where it was shared with a number of physicians, including Queen Elizabeth's physician, who we believe employed it with the Queen to help her with her migraines. So here's a plant. It's industrial, it's medicinal, it's spiritual, and for thousands of years it moves across the country. The Spanish conquistadors brought it to South America, where it was later named something sounding like marijuana. Up here in India and up here it was referred to as ganja. When O'Shaughnessy brought cannabis from India, he called it cannabis indica for India, cannabis from India. And that we still use that term today, indica and sativa. And we'll talk about that terminology a little bit more. And in the United States, we used cannabis at the end of the 19th century and the beginning of the 20th century for hundreds of ailments. Eli Lilly, other pharmaceutical companies were producing bottles of cannabis tincture for all sorts of problems, including anxiety and pain. It was helpful as a remedy to reduce cramping associated with childbirth. But in 1920 and 1930, the Marijuana Tax Act and other regulations that were put in place to make cannabis illegal eventually started the whole prohibition that we now know has lasted up to the current day. So even though cannabis has been useful for 5,000 years, probably even longer than that, because we have other remnants of individuals that were living in the Arctic that were frozen with their cannabis bags, and so we don't have written records of that. And there's been other individuals that have been exhumed from their spiritual graves that also have cannabis seeds that actually turn out to be potent. We can do analysis on that. But the point I'm making is for 6,000 years or longer, it was used. And it was used widely for a variety of conditions. It's only in the last 100 years, due to prohibition, not just in the United States, but due to the it was 1961, the countries around the world all got together and decided, yeah, we're going to all agree that cannabis is illegal. Last 100 years. Now only in the last 20 years or so has cannabis been back available as a medicinal remedy, beginning with California in 1996. So this medication has been tried and true as a plant, not just for industry, but for medical purposes for 5,000 years or longer. It's important to understand the lexicon. My wife told me that I'm really not that smart if I just learned the words, and so now I'm a doctor. So it all comes down to words. What are the words? Cannabis, sativa, and indica represent different types of cannabis varieties. The same that you have different types of grapes that make different kinds of wine. Hemp is a form of cannabis. Cannabis is a plant that has different properties. If the plant has a fibrous, long stalk and the flowers have very little THC, which is the psychoactive component, we call it hemp. If it has greater than 0.3% THC, kind of an arbitrary designation, we call it marijuana. It's all cannabis. That's why we call our clinic the Neurology of Cannabis, because it's the all-encompassing name. Carl Linnaeus came up with the name cannabis sativa to refer to cannabis that was cultivated. That's all that means. But hemp is a form of cannabis. Marijuana is a form of cannabis that has higher THC levels. Is that clear? The cannabinoids are the molecules that are in the cannabis plant. Now, I don't know if there's any biochemistry lovers out there in the audience, but I love biochemistry. It explains things. It makes things, for me, evidentiary. It makes things rational. It makes them logical. If you give me a bottle of snake oil and say, okay, this is going to help you with your rheumatic fever, I'm going to say, okay, well, how does that work exactly? How do I know it's anything more than just snake oil? But with the biochemistry that we are learning more about all the time, we have a framework for understanding why cannabis works, and the evidence for why it works helps propel me as being a caregiver. Otherwise, I wouldn't do it. And we're going to talk a little bit about the cannabinoids. Those are the molecules that have the biological effect in the plant. Terpenes are another molecule that's in the plant. Those are the aromatic molecules. You know, cannabis has a very strong odor. You know, ooh, that smell, can you smell that smell? Oh, anyway. The terpenes are the aromatic molecules. THC and CBD have no odor. You can smell cannabis a mile away because of the terpenes, and these aromatic molecules also have biological effects. That's why some cannabis makes you a little sleepy, some can make you elevated, some can help with depression, other cannabis can help with addiction. We do a specialized individual treatment approach based on terpene profiles. We also use cannabinoids to help create a personal approach so that the cannabis is effective without being intoxicating for people that need to work and function all day. The endocannabinoid system I'm going to get into shortly. The administration methods, many of you may be familiar with the current vaping health crisis. Vaping is the process of taking a cannabis extract and heating it so that the molecules become a vapor. They're aerosolized and inhaled. So you can also heat up the flower without burning it. When you burn something, it's called combustion. When you light a cigarette, you're combusting the plant material. When you light a joint or a bowl of cannabis flower, there's combustion, there's burning. It's the burning of the plant material, whether it's tobacco or cannabis, that creates certain toxins like hydrocarbons and tar. So that's combustion of plant material. When you heat the plant material or heat the oil without combustion, you release the molecules without releasing the tar and hydrocarbon that can be more dangerous. So vaping is actually safer than smoking because there's no tar or hydrocarbons. Now this gentleman wrinkled his forehead as soon as I said that, because you've seen in the news every day that vaping is killing people. We have, as of this past week, 1,800 confirmed cases of vape-related pulmonary illness, 32 deaths, I believe. But those people are not getting sick from the cannabis extracts or the THC, they're getting sick from the other junk that's in the vape cartridges that are being produced underground without regulation and contain contaminants like vitamin E acetate and pesticides like myclobutanol. So we don't have the whole picture yet, but the vape-associated pulmonary illness, VAPI, and you can go to the cdc.gov website, they have updates all the time on this. Those terrible pulmonary conditions that people are getting from vaping, not just cannabis, but also nicotine, is related to these other toxins that are tainting the vape cartridges that are being produced in someone's garage in Southern California. Don't get me going on this. There's more to come. If you have questions, keep them in mind, because there'll be time for questions towards the end. So you don't have to vaporize flower or the concentrates. You can smoke it. You can also create an extract that allows you to absorb it in your mouth. That would be the tinctures. And you can get that absorbed in the mouth or in the oral mucosa. Swallow it down. You can have cannabis therapy available to you as edibles, although in Florida we don't have food products with the cannabis therapy in it yet. We just have capsules and liquids to consume. But I want you all to know that when you consume cannabis, it's metabolized by the liver to a more potent molecule, right? 11-hydroxy. I know you know this. And so when people go on their cannabis tourism vacation to Colorado and buy their candy bar and eat more than they should, they're in a bad way. They get really stoned. They can't walk, they can't talk, they end up in the emergency room, and it takes about 6 or 8 hours for that basically overdose of cannabis to wear off, and then they're fine. There's no permanent, ongoing problems with that. It's just they took too much. They took a toxic amount. They had an overdose of sorts. They got sick with inability to move and sometimes nausea. And of course, it can make you very afraid. Sometimes people get paranoid and upset because they don't know what's happening. But no one dies from an overdose of cannabis. Even if you eat that whole chocolate bar, no one dies. In fact, cannabis is so safe from that standpoint that I feel extremely comfortable using cannabis therapy with patients that have never used cannabis before. Sometimes in cancer care, we use high doses, but it's not going to kill you. Opiates will kill you. Xanax, Valium, which are the benzodiazepines, they will kill you. Why? Because they depress the respirations. They bind to the brainstem, opiates and benzos, and create a situation where people fall asleep and they don't wake up. That's why everybody with these opioid overdoses, they just don't wake up. That doesn't happen with cannabis because, I'll get into this more with the endocannabinoid system, that's my favorite part, remember? There's no receptors in the brainstem for cannabis. So the part of the brain that controls respirations is not affected by cannabis therapy. You can't overdose on cannabis. I'm emphatic. And this is an important word right here, dispensary, because that's where you have to go to get your cannabis therapy. Now, I don't sell cannabis therapy. I don't touch the plant. I'm not allowed to. I'm not even allowed to tell you to take it. That would be a prescription, because cannabis is not legal on a federal basis. And prescriptions are doctors telling a pharmacist to dispense a drug. If I tell you to take a drug or go to a dispensary and buy this particular thing, I'm telling you what to do. It's like a prescription. I'm not allowed to do that. I can only make what we call a recommendation. It's kind of ridiculous, but the point is, I don't touch the meds. I don't get any kickback, not yet at least. Maybe we can talk about that. But we send patients to the dispensary, and you've seen these popping up around town. I believe many of you have either heard or read or seen because they are popping up. And there are different companies, and in Florida, the dispensaries are owned by the growers. The cannabis that you're using in Florida for medical purposes is grown right here in Florida. And then it's manipulated in a way to create either vape cartridges or edible capsules or topical creams or oral tinctures. And then it's sold at the dispensary. Those companies that grow and modify and sell are vertically integrated. So they are now, at least. So it's not a pharmacy, it's a dispensary, and it's not a prescription, it's a recommendation. Kind of trivia, cannabis trivia, actually. Okay, so this is Dr. Richard Schultes from Harvard. In 1971, examining cannabis plants in Kandahar, Afghanistan. He's an ethnobotanist. Do we have any botanists in the, no? Anybody grow their own? No, you don't have to say right now. Dr. Schultes was doing this work in the 1970s where he was trying to understand the differences between different cannabis plants, and that's super important. This is a male broadleaf plant here. This is a female narrowleaf plant. These plants reproduce. There's males and females. The females have the flowers. When the males and females get together, the females produce seeds. Some of you may remember back in the day having to clean your weed of seeds. Nowadays, all the cannabis pretty much that's sold is without seeds. The other word for without seeds is sensimilia, right? Dr. Schultes was trying to figure out the different properties of the different plants. And what he found out was that some plants had higher concentrations of cannabinoids like THC and others didn't. So his category was to break everything down into hemp and drug. So he would have a narrow leaf hemp plant or a narrow leaf drug, broad leaf hemp, broad leaf drug. So that's botany. There's a lot of people that argue about these things, but the point is it's all cannabis, right? It's all cannabis to me. Marijuana or hemp is only defined really by how much THC, which is the psychoactive part. The hemp that's not full of THC is used for industrial purposes. You can get CBD from hemp, certainly. You can also get CBD from a marijuana plant as long as it's got less than 0.3%. So the growers that are creating these plants are doing all sorts of wonderful things to create different varieties. These are cannabis plants. The molecules in the cannabis plants are called phytocannabinoids. Phyto means plant. The cannabinoids that are made in the laboratory are synthetic. And the cannabinoids that we have in our own body inside are endocannabinoids. So we're going to talk a little bit about each of those. If you look closely at those plants that Dr. Schultes was examining, you'll see that in the flowering tops, there are these, they're called trichomes. And what they are is they're glands. They're little factories for cannabinoids and terpenes. These glands that live on the top of the flowers create the medicine, the cannabinoids and the terpenes. And if you take this plant and shake it, and all those little glandular tops fall off, and you save those, that's hashish. The flower itself can be up to 25% glandular trichomes. So it's a very efficient process. The cannabinoids and terpenes are produced in the glandular trichomes. That's something else that'll come up on trivia at Gecko's some night, probably not this week. Okay, so that's on the plant. So these are the molecules that are produced in those capitate glandular trichomes. THCA, which is tetrahydrocannabinolic acid. This is the molecule THC that makes people high. It also has lots of other really important effects. But it won't make you high until the acid part is cleaved or removed. So if you take a green cannabis plant and you pop that flower in your mouth and swallow it down, you won't get high, you won't get stoned, because the THC is in the acid form. In order for the THC to become bioactive or more bioactive, you have to decarboxylate it. You have to heat it up. That's why if you don't leave your brownies in the oven long enough, nothing happens. You have to heat up the flower material to remove the carboxyl group and convert THCA to THC. That's called decarboxylation. The other cannabinoids that live on the plant are all in the acid form. And there are biological effects of the acid form. In Poland, there was a study done in patients who regularly took cannabis plants and created something like smoothies from them, or tea. They would consume, and it turned out that it was very helpful for preventing Parkinson's disease, THCA. So cannabinolic acids convert to more active biologics, when heated. Okay, synthetic cannabinoids. So in 1986, Marinol, which is a synthetic form of THC, was created in the laboratory. It's a single molecule, delta-9 tetrahydrocannabinol, not the acid form, the active form, not the acid. Delta-9 tetrahydrocannabinol, the active ingredient in cannabis, was built in the laboratory to provide medication for people suffering with AIDS-related cachexia and chemotherapy-related nausea and vomiting. And it was approved by the FDA. And it was called Marinol, and it was put out there in the market. And so oncologists started prescribing it. And infectious disease docs that were treating AIDS patients were using it. And it helped, but the majority of patients didn't like it. And they kept going back to their own bud to smoke, because the THC molecule by itself does not work as well as when it's surrounded by all those other cannabinoids and terpenes. And now we have studies showing that when you treat someone with a THC molecule, or for that matter, a CBD molecule or isolate by itself, you get a certain effect. But when you put the two together and throw in some terpenes, you get a much better effect. And we call that the entourage effect, because it takes, I was going to say it takes a village, but it takes a number of different cannabinoids and terpenes, the way God produced it on the plant, and in her wisdom, she knew that we were going to use the whole plant. And that's what people have done over the ages. These single molecules that are created in the laboratory are the pharmaceutical industry's attempt to supplant the benefits of cannabis as a plant and create a product that they can sell. And you know what? It just doesn't work that well. And we know that from patients' reports, and we know it also from laboratory data. And in the United States, and for that matter, the rest of the world, in the 20th century, we doctors have all been trained to understand what's called the single molecule hypothesis, that in order to safely and effectively treat patients, we should use a single molecule that's been created in the laboratory and given to patients and tested as safe, single molecules. That may be okay for lots of things, insulin, for example, but when it comes to plant medicine, there's many, many different molecules in the plant, and it's creating an effect biologically that you cannot reproduce with a single molecule. So that's the difference between plant medicine and herbology and conventional Western medicine, which has been pretty much taught to all of us docs right up until the present day as the way we should practice medicine. So the entourage effect. Okay, now the endocannabinoid system is our own biological machinery that is in place to bind molecules in our own bodies, okay? Let me put it to you this way. Have you guys ever heard of the runner's high? You know, people run, and what's that molecule in the brain? Endorphins. Endorphins inside the body, like endocannabinoids. But instead of morphine, it's endogenous morphine, or endorphins. Endorphins are our body's own molecules that bind receptors and create joy and relief of pain, analgesia. Those poppy plants that people have been using throughout the ages to create heroin and morphine and things like that, the receptors in our brains were not there to bind the plants. The receptors in our brains are there to bind our own endogenous molecules. What happened historically was in 1964 in Israel, Professor Raphael Mechoulam was able to describe the THC molecule. And that's great. That's from the plant. That's a phytocannabinoid. Then in 1988, Alan Howlett, a professor at St. Louis University, discovered that there are receptors in our bodies that bind the THC molecule. So that's how THC works. It was a big revelation. We have receptors in our bodies. They're called endocannabinoid receptors. But why are those receptors there? Did she put them there because she knew we were going to use this plant? No. Those receptors are there because we have molecules in our own body called endocannabinoids that were discovered in the early 1990s, again, by Professor Mechoulam's lab. So without taking a single puff, we are in our own bodies functioning with our endocannabinoid system. Those molecules in our body are anandamide and 2-arachidonylglycerol. Those are in our body binding the cannabinoid receptors. This cartoon here, this little graphic rather, depicts two nerve cells, neurons. Now we learned in neurology, some of you may remember this from your neuro course in high school, although that's probably a long time away for this guy here, that there's chemicals, there's neurotransmitters that sit at the edge of one of these neurons, and the neurotransmitters cross the synapse and bind to the next neuron. So that's GABA, for example. You guys have heard of gabapentin, perhaps. These molecules are neurotransmitters. They tell this postsynaptic cell what to do. And this is how the nerves communicate. This is science. This is how it works in the brain. Chemicals go from one nerve cell to the next, and that creates a sequence of events that we know as consciousness and moving and eating and everything. Nothing happens if the nerve cells don't communicate with each other. Like, for example, if you have a shortage of dopamine, let's imagine that this was a dopamine cell, and you run out of dopamine, and there's no binding down here. What happens? You develop Parkinson's disease. That's dopamine deficiency, and we give people Cinemet to compensate for that. What if you have serotonin up here, and you run out of serotonin? You get anxious, and so if you don't have a turkey nearby, you get a serotonin agent like Paxil or Prozac, and you restore the serotonergic. So that's neurotransmitters. Now, what happens with cannabis, or rather endocannabinoid system, sometimes these glutamate or GABAergic neurotransmitters do not function properly. Sometimes there's too much glutamate, which is, for example, what happens after head injury. Or there's not enough GABA, which is what happens oftentimes in people with muscle spasms and anxiety, for example. If there's a problem with this neurotransmitter system, what is the nerve cell supposed to do? Well, that's where the endocannabinoid system comes in. The endocannabinoid system is a modulator of the other neurotransmitter systems. Endocannabinoids are created on demand in the postsynaptic neuron, and then there's a feedback to the presynapse to either shut down or produce more of whatever you need. So it's a retrograde adjuster to create homeostasis. That's how the endocannabinoid system works in the brain. One of the ways. If you don't have enough endocannabinoids, what happens to you? Well, we think you can develop conditions like fibromyalgia, chronic migraine, irritable bowel syndrome, a whole host of problems that we're now learning may be associated with endocannabinoid deficiency. So what happens when you have a deficiency? You try to supplement that. And there are some ways to do that, including taking phytocannabinoids as your supplement. I have chills. Do you guys have chills? No? Are you feeling me? It's remarkable, right? This endocannabinoid system was described in 1988 and then through the early 1990s. I graduated medical school in '87. I heard nothing about this. If you do a picture of the brain and you look for the receptors, these endocannabinoid receptors, they're more prevalent than any other receptor in the brain. Not only that, but there's endocannabinoid receptors in the rest of the body also. They're the CB2 receptors, and they function in the immune system. And if you take a picture of those receptors, which we can do with a study called autoradiography, they're all over. They're in the endometrium. That's why it works to help moms with cramps, and endometriosis for that matter. They're on bone. It helps with osteoporosis. We're seeing that in the laboratory. It helps create a homeostasis in the bowel so that patients that have overactive bowel or underactive bowel get better using cannabis to bind those cannabinoid receptors in the bowel. It reduces leaky gut and the inflammation that goes along with that some people think is at the root cause of all the autoimmune problems that we have now in the 21st century. When you go to your doctor when you go to your doctor during your appointment and you say, hey, I saw this talk on cannabis and, I think maybe it's good for me, and your doctor says, well, it may be, but there's just not enough evidence. I totally understand that because, we never learned about it in medical school. The med students still pretty much are not learning about it, by the way. And we learned that in order to make a careful decision for our patient's health, we need to use data from randomized, controlled, double-blind, placebo studies. This is the type of evidence that we learned beginning in the 1960s, actually, that was really the only way to make a good judgment on what therapy to use. It has to be a randomized controlled study because that way you know that it's not placebo effect. You know that what you're doing is having a benefit. But that's only one type of evidence. There's other types of evidence. Patients' values and preferences, that counts as evidence. What if someone comes to you and says, you know what, I don't like that Marinol, but when I smoke a doobie, my nausea from the chemotherapy goes away. Doesn't that count as evidence? Sure, we call it anecdotal evidence because it's just one person, but that counts. So multiply that times 5,000 years and hundreds of thousands, perhaps millions of people that have been using cannabis for their benefit, and I think that's a body of evidence that we can invest in. And then of course there's clinical judgment. So, I have patients, lots of patients, but I have room for you guys. And I'm learning things. I'm learning things from my patients. I'm learning that this young 3-year-old that came to visit me with his mom because he had autism, and we know that a 20-to-1 CBD to THC tincture is effective for autism because the work was done in Israel. I know that if I try that with this young boy, I'm not going to hurt him. And I can increase the dose carefully and maybe help this child and their family just because I'm willing to take that risk on their behalf. They're willing to take the risk. We don't know that it's going to work, but 5,000 years and thousands of patients, even in present day, teach us that this medicine is safe. And so I use my clinical judgment, I use the experience of other patients, and even though there is no randomized control study of autism and cannabis use, there isn't, I'm going to go forward and I'm going to say, okay, we have enough evidence to try this. Now, when I first graduated medical school, I wasn't that bold. I was scared. I'm only going to use treatments that are from randomized control trials. And a lot of people, doctors, of course, still feel that way, and that's fine. I'm going to share with you a couple of studies that are pertinent to cancer care. This study was done in the UK and published in JAMA in 2015, and basically it's what's called a meta-analysis, which means it's a study about other studies. It's not an original study. So Whitting and colleagues looked at tens of thousands of articles on cannabis therapy and whittled it down to 76 or so articles that had scientific merit. They searched all the databases for as long as the databases were in place and came up with 76 studies that had some control group so that they can say, okay, cannabis in these studies did have evidence for helping with chronic pain and spasticity. There was moderate quality evidence. That was because those studies were controlled with placebos. And the vast majority of those studies were done with this pharmaceutical company called GW Pharma in the UK that produced a cannabis preparation to help with pain and multiple sclerosis spasticity. And they did this study. So we have GW Pharma to thank for that. Plus, we have studies from Marinol and the other synthetic cannabinoids. Of the 76 or so studies, there were only 2 that actually were flower that people were smoking, because we just don't have standardized laboratory or clinical evidence yet. But there was enough to at least say that cannabis in this huge meta-analysis was good for pain and spasticity, which is a problem not only for multiple sclerosis, but also in patients with spinal cord injury. And there was also evidence suggesting that it was positive in nausea and vomiting due to chemotherapy. But that was low quality evidence in the way that the authors looked at it. Even though we have hundreds of thousands of patients that will testify that it's high quality relief they get from their cannabis, the studies only came up low quality because there wasn't enough of blinding or so forth to do the study in a conventional way. They also determined that it was helpful for sleep and Tourette's, but nowhere did they see that it was helpful for Parkinson's disease or glaucoma. And we know that it's helpful for those conditions and lots of other conditions. Epilepsy. We know that it's useful for epilepsy. The FDA in June of 2018 approved a medication for epilepsy called Epidiolex, which is basically CBD. So we know it. But it still, it still doesn't always come up on the radar when you're looking for randomized control studies, although, in all fairness, the Epidiolex study was after these guys, so they probably would have included it. The point I'm making is there's different forms of evidence, and the Whitting article in JAMA is often cited as providing a narrow number of conditions for which evidence exists. But we know, I believe, that the definition of evidence should be broadened. In Israel, Lev Shleida in Meshulam's group studied 3,000 cancer patients between 2015 and 2017. What they did was, in Israel, cannabis is available for medical use. It has been for some years. They took patients that came into the cancer clinic, everybody, all comers, and asked them about their symptoms and whether or not cannabis was something they were interested in using. And then they followed these patients to see how the cannabis helped this wide range of cancer patients. So this is a big study, all right? 3,000 patients with cancer. Does this count as evidence? I think so, even though it wasn't placebo-controlled or blinded. It's anecdotal, but on a big scale. It's a survey. So this, again, is not legible from where you're sitting, but I just want to show you that all these different types of malignancies were represented in this study. Breast, lung, pancreatic, and so forth. And this is the result in pain relief, regarding pain relief for the patients who, prior to treatment, the blue bars, prior to treatment, 10 represents the worst pain imaginable. So this number of patients reported the worst pain ever. And you can see that in this pain intensity scale, the blue bars represent the fact that most patients were having terrible pain. Whereas after treatment with cannabis, there was only very few people that were complaining of terrible pain. More than 70% initially, and then less than 20%. So that's a dramatic improvement in pain intensity in a wide group of cancer patients treated with cannabis. I think that counts. Some of the main problems that cancer patients were complaining of were sleep, fatigue, digestion, anxiety, nausea and vomiting, and lack of appetite. And you can see here that the majority of patients either improved or their symptoms disappeared completely, although there was a group that did not have relief, but those numbers are smaller. Here's another bar graph showing overall quality of life assessment as assessed by the patient themselves, showing that prior to treatment, the blue bars, the quality of life index was bad, or very bad, for the majority of patients. Whereas after 6 months of therapy, there was a dramatic change, whereas most of the patients either felt good or very good. Quality of life. It's a personal report assessment. And adverse effects, again, not really to be read by you guys, but I just want to show you that in general, and this goes along with other studies of adverse effects in patients using cannabis. The most common adverse effects are dizziness, dry mouth, nausea, fatigue, somnolence, euphoria. This is in descending order of statistical power. And there are rare cases of psychosis and paranoia down here, but in general, these adverse effects, which by the way, only had to occur once in the 6 months. So if that individual was using cannabis and they had cancer and they reported fatigue, that counts as an adverse effect of cannabis, even though they certainly could have had fatigue due to a number of other causes. So these side effects were for the most part mild. So in general, we have to be careful about side effects, including psychosis, which although it occurs rarely, gets a lot of press. And if you read the pros and cons, or hear on the news the pros and cons for cannabis use, this psychosis issue always kind of bubbles to the top. I think it has, it's got like curb appeal or something. But the truth of the matter is, cannabis does not cause schizophrenia. It can cause a temporary psychotic reaction if you eat too much or use too much and you start feeling paranoid, and you can have a hallucination, but then that goes away. But in patients, or I should say in individuals that are using cannabis, they do not, we don't believe they do not develop schizophrenia from that drug. And the reason we know that is from epidemiological studies in countries where cannabis becomes legal, and over a period of time, the usage of cannabis goes way up, whereas the incidence of psychosis stays the same. That doesn't stop other people from doing other types of studies trying to prove that cannabis causes psychosis. But I've seen those studies and I don't believe that they're convincing due to a number of factors, including sample bias. So let's say you have psychosis, let's say you have schizophrenia, and you're using cannabis. Does that mean that the cannabis caused the schizophrenia? No, it's a correlation, it's not a causation. So there's a difference there. So we have to be careful making statements about causality when there's really just a correlation. So other important things to consider when using cannabis therapy has to do with pregnancy and lactation. These cannabinoids I was telling you about, they're lipid molecules, and they like to stay with other fatty or lipid molecules. They're lipophilic, we call it, and certainly breast milk is got its share of lipids in it. So in a lactating mom who's using cannabis, the nursing child will get some of that cannabis in the breast milk. If a pregnant mom is using cannabis while pregnant, is there going to be a delay in development or a problem with the baby? Is there going to be some birth problem? And if a young child starts using cannabis, does it slow development or affect the development of the brain? So we have lots of interesting studies on this, and I have strong opinions on each one of those things. You're not surprised. In general, we don't want pregnant or lactating moms to use cannabis. And we don't want children to use THC specifically, because the brain does continue to develop into the early 20s. And we don't want to take a chance that we're going to mess up someone's own cannabinoid system, their endocannabinoid system, by giving them supplements they may not need, all right? So that's the way we do things now. We have seen studies. There was one really interesting study in Jamaica by Melanie Dreyer, where cannabis, is part of the culture in large parts of Jamaica. It turns out that pregnant moms were compared with other pregnant moms who were and were not using cannabis, and the kids came out fine. In fact, the kids that were born from moms that were ganja users actually did better. And that may have something to do with other cultural factors, but they certainly didn't do worse. And so There's more we can talk about having to do with those studies, but my opinion is no, we don't recommend it. But frankly, it's probably not as dangerous as some people make it out to be. There is a cannabis use disorder which occurs in young people or older people, but usually it's the younger population that uses a lot of cannabis. So if you're getting up in the morning, wake and bake they call it, if you're getting up in the morning and you're inhaling large amounts of cannabis by perhaps a process called dabbing, which is where you inhale a highly concentrated form of cannabis extract, maybe 20 or 25 milligrams of THC in one puff. And you do that all throughout the day, you can develop a cannabis use disorder where you don't function normally in society anymore. You're always looking for your next dab, or you don't want to go out unless you're stoned. You don't participate in activities that normally you would. So like any substance, it can affect the way you behave. I know people that are like that with caffeine, and maybe it's a loose analogy, but if you're always looking for that next latte and you're willing to miss the train to get it, that's a problem. Alcohol, people have alcohol use disorder. I can't wait to get that drink, and even though they know it's not good for them, they still can't stop themselves from having that martini. Cannabis is the same way. People develop a social impairment as a result of a dependence on cannabis. It happens. There's a hyperemesis syndrome, which has to do with loss of regulation of your own gastrointestinal system because you're using too much cannabis. And these patients show up in the emergency room, they're vomiting, they feel compelled to take a hot shower. For some reason that helps them. We have theories about that. And then they go through this big GI workup, sometimes for years. And it turns out that they have hyperemesis syndrome, and the cure is to stop using cannabis, and in a week, they're better. But do the majority of emergency room doctors that see these young people come into the hospital, do they know about this? I don't think so. In Colorado, they do. In Oregon and California, they do. I had someone in the office the other day who had it. And I was like, listen, you got to stop this, Is it
only with THC in it?
Yes. You can use way large amounts of CBD and not develop problems. But that's a THC-related issue.
Do you feel that there's a benefit to it?
To what? CBD without THC? Yes, I do. Well, Epidiolex, that medicine for seizures, is all CBD. It's great for childhood epilepsy. Cannabis is metabolized by the liver, enzymes, the P450 and other liver enzymes that are in charge of also metabolizing 70% of all the medications out there. So when you have an enzyme that's sometimes working on two medicines at the same time, it can create a problem. For example, there's a seizure med that kids take called clobazam. And we know that if you use cannabis, even CBD in high amounts, and it'll enhance the effect of the clobazam, and the kids get excessively drowsy. So there's a medication interaction right there. With cannabis with high dose, it can throw off your Coumadin or warfarin level. Yes, there's antifungal medicines that don't work as well when you're using large amounts of cannabis. So there are drug interactions. Federal benefits, people are concerned about federal benefits because cannabis is not legal federally. So if you're a veteran and you are interested in taking cannabis for PTSD, for which it's very effective, you can talk to your VA physician about it, but that physician can't recommend you take it. Nor can you have the cannabis products on federal grounds at the VA hospital. So the VA will not, you don't lose your VA benefits if you use cannabis, if you're a veteran. You do not. In fact, the VA put out a statement recently spelling all that out. So the vets keep their benefits, but the whole VA machinery can't participate in the cannabis therapy because it's federally illegal. If you are active duty military, then that's a Department of Defense issue. It's not a VA issue. and there's zero tolerance for cannabis for active military. And then, of course, there's federal regulations because of the illegality of cannabis on a federal basis. If you cross state lines, that's a federal offense, even if you go from one legal state to another legal state. The process of crossing the border is a federal offense. So patients ask all the time, can I take my cannabis to North Carolina? Can I take it back up north to Michigan with me? And the answer is no, you can't. Even though it's going from one legal state to another, in the case of Michigan at least. And then there's employment concerns in patients who are on cannabis therapy who have employers with a zero tolerance policy. If your employer in Florida says, no, you're going to get urine tested, and if it's positive, even if you have a medical card, you're going to be fired, you're fired. So it's not a right to work issue, it's a right to fire issue. That's different in different states. And certainly if you work for the Department of Transportation or Post Office, then you can't use also, because then that's a federal thing. Gun permits, people ask all the time about their concealed carry permit. People love guns in Florida. I'm not one of them, but that's a non-issue. But the gun permit that you fill out when you buy a firearm or renew your certification has a question on there specifically about medical cannabis. Even if you're medically approved for cannabis therapy, you cannot buy a firearm or renew your carry permit legally. Now, the Department of Agriculture here in Florida, Nikki Fried, is a gun enthusiast, and when she was elected, she also helps run the cannabis Department of Agriculture, and she wants her gun. So she was standing, I believe, on the steps of the Capitol in Tallahassee, and it was like, you're not taking my gun permit, and you're not taking my cannabis card. So, I don't know how much enforcement there is going to be in Florida, but people are really careful about this because, again, it's a federal offense. You cannot lie on that gun permit form. But if you already have a permit, and you're not going to buy any more guns, I think you're okay, because you're not lying on the form. If you are interested in starting cannabis therapy, call me or check out our website, neurologyofcannabis.com. It has everything here spelled out. You would come into the office or go to some other cannabis doctor's office where you would have your medical situation discussed. You would be educated on how to use the product, and then it has to be, the doctor has to enter the information into the registry as part of the application process. You can have a caregiver also entered into the registry so that if you're too ill to go to the dispensary and for some reason you don't want the medicine delivered, which is a nice option for some people, your caregiver can go to the dispensary or sign off on it for you. Within 10 days, your application is approved. It takes about 5 days for the money to go through because you have to send $75 to the state, and then it takes about 5 days for the application to go through. So it's 5 plus 5 actually. And then you get an email, congratulations, you're approved, and then you can go to the dispensary, not pharmacy, and you can begin the therapy as we discussed, which usually involves a titration period where we start low, go slow, and then titrate up to get the desired effect. Or if there's side effects, we back it down. The things we consider when dosing cannabis has to do with what variety of cannabis we're using to get the effect we need. So do you need something to help you sleep and reduce anxiety? Do you need something for daytime to improve energy levels? The varietal names like Bubba Kush or strawberry cough, all these cannabis varieties have these funny names. Durban poison, you guys ever hear that stuff? But nowadays, there's hundreds of different varieties of cannabis, and people use the word strain. What strain of cannabis are you using? I don't particularly like that term because we use the word strain to refer to viruses and bacteria, not varieties of cannabis. But we can talk about that over coffee sometime. You can inhale it, put it in your mouth, swallow it, or get it absorbed on the skin. Some patients with inflammation in one particular area find that using topical is very effective and does not cause any impairment. even though it has THC in it. And then, of course, we have to discuss the potency. How much CBD and how much THC is going to get the effect that you need without causing side effects. There you go. Those are the things we talk about when deciding what kind of therapy you're going to use. And then finally, I believe that taking all this information together, the 5,000 years, right? The experience that we're having in the clinic and what people are having around the world, I believe that all that history does support the use of cannabis therapy, even though we don't have the classic double-blind randomized control studies. And I think that with the advent of cannabis therapy around the world and the repeal of prohibition, we're going to be able to do these studies, but we can't do them now quite well enough because prohibition is still in place. And so I believe that cannabis therapy is useful, and I believe that the benefit outweighs the risk.